All right, so we had some great presentations this morning talking about neurobiology of addiction and pain and many of the underlying concerns our patients are having. And I'm really gonna get down to some nitty-gritty practical stuff. So I know that many of you are in the trenches with these patients. You're having these difficult conversations. And what you also need are some tools. What are some actual tools you can use, principles you can use for a patient during a taper? Most of us were not taught this in medical school or residency, and it's been kind of an on-the-fly probably for most of us. So I'm going to give you some hopefully foundational tools that you can use to help your patients to successfully taper from difficult medications. Those are my disclosures. So our objectives, we're going to talk about what are some of the background points that you can emphasize with patients to help educate them about the risks of opioid therapy. We are going to do some math. So if you've got a calculator on your iPhone, get that ready. To help calculate some morphine equivalents per day. We're going to go through steps to successfully taper opioids and benzodiazepines. All right, step one of a taper. And this is all, again, in the setting of using much of that patient-centered language that you just learned from Brad. So I'm not going to necessarily emphasize these specific things you should say, more general points. What are the steps you're doing? So step one is doing all that great patient-centered communication, education to secure commitment, help educate the patient of the risks. So it's really important that for a patient who's been prescribed these medications for 20 years, you help explain why there is a shift in practice. Why are you suddenly saying that opioids are no longer safe? Patients don't necessarily understand that shift. They don't understand why these medicines are suddenly unsafe when they haven't necessarily experienced harm in the last 20 years of their treatment. So explaining the things about the secular trends within our society, the heroin epidemic, is important that they're aware that that's occurring, that there's poor evidence for opioids, there are many harms, there's options, and it's important that all of this is done with empathy to really sort of try to put yourself in their shoes, that you're really coming to them and suddenly kind of changing a course that's been, working for them for the last several years. So the way you can do that in a very patient-centered way is many of the things that Brad was talking about, and really keeping the focus on safety, using a risk-benefit framework. We do this in medicine all the time. There's a medicine that we prescribe that we don't think about the risks and benefits of the medication or the therapy. We're not judging the patient when we do this, we're judging the therapy. So we're not thinking, is this patient good or bad? Does the patient deserve this therapy? Should the patient be punished or rewarded? Should I trust this patient? These are not things that we're thinking about when we prescribe insulin. These aren't things that we think about when we prescribe lisinopril. Rather, we're thinking about, do the benefits of this therapy outweigh the effects, the bad effects on this patient and society? So again, really making sure that your judgment in this situation is about the treatment, not the patient. And every time that I keep that at the forefront of my decision and my conversation, I end the visit and I know that I did what was best. I know that I practiced medicine in the way that was safe and appropriate and in a way that I feel good about. If I get out of that framework, things usually don't work well. So some of the evidence you can use are some of the background information that's important to share with patients. We really don't have good evidence to suggest that there's long-term efficacy or effectiveness for opioids. Recent AHRQ study that was done showed that most of the studies that have been done have had very short time frames, and they've been very, very specific. So there's been no study of opioid therapy versus no opioid therapy that's been evaluated for longer than a year on outcomes that are really important to patients, like pain outcomes, function, quality of life, opioid abuse, or addiction. The studies that have been done have been very specific about maybe function of a shoulder or a limb or something very, very specific. Not generally things that patients really care about necessarily, and certainly not studies that are long-term in nature. We understand over time that increasing doses of opioids does not appear to increase or improve pain control. And we also know that I'm going to talk about in just a minute about doses that are very related to risk of overdose. And as Tom was saying, pain that we can expect of all the studies that have been done, we know that for opioids, we're only at best can expect a 20 to 30% pain reduction, and that probably diminishes over time. So these are all important things that you understand in the background of having the conversation. Background number 2, opioids are the most dangerous medication I can prescribe and could seriously harm you. Essentially, opioids are a primary care provider's chemotherapy. There probably is not any more dangerous medication that we could prescribe. So it's very important that we keep that in mind, and we acknowledge the fact that there's been a lot of harm that these medications have caused for patients. We're seeing now in this recent study in the mortality of white non-Hispanics that poisoning has exponentially increased over time. It's far exceeding other causes of death. And we're seeing this not just in this population of patients, we're seeing this across the board, across the United States, and we know that there is currently an epidemic in our society. Number 3, we know that unintentional opioid overdoses are increasing exponentially, and we know that risk starts to occur at doses of morphine equivalents over 50 milligrams. So there have been several large studies, all listed here, that show that increased effect. And these are not small effects. These are very rapid increases of overdose risk. In Washington, since they have tried to create dosing limits and curb some of the overdoses that they've seen, they've shown that with some of the dosing limits, they've actually seen reductions in deaths. So we know that having policies, having community standards such as a dosing limit actually can have a very profound effect on overdose deaths in general. And that's just from one state. Number 4, it also seems that new literature is suggesting that the rate of opioid use disorder seems to increase at higher doses that are prescribed over a longer period of time. This is, when I was preparing for this talk, this was the first time I had really kind of mapped this out in this way, and I'm continually kind of dumbfounded by it, that for a chronic high-dose user of, or someone who's been receiving high-dose chronic opioids, the adjusted odds ratio for developing an opioid use disorder is 171. I mean, that just makes me speechless. I mean, that's a huge number. It's kind of horrifying that we're putting patients at such risk. And you see that increases over time. Number 5, it's important that patients know that physical dependence is a side effect of opioids. It happens, unfortunately, when you're prescribed these medications, and it can happen even after just 2 weeks of use at a specific dose. Patients don't necessarily know that this is a side effect, and when they start to have withdrawal from opioids, they don't really know what's happening, like what's going on. Why do I feel so bad now? Why is my pain worse? Why am I anxious? Why am I depressed? Family members don't know what's happening. They're concerned about their family member and saying like, what's happening to you? You stopped opioids, does this mean you're addicted? Well, no, it's not the same thing. Being physically dependent on a medication, meaning that your body has developed some physiologic adaptations is a normal process that occurs with opioids. All right, get ready. We're going to do some math in a minute. Not quite yet, though. Okay, so step number 2, diagnose. You have to determine what is the indication for the taper. And these are some of the indications that you might find. So are we dealing with a substance use disorder? That could be opioids, alcohol, benzodiazepines, what have you. You need to determine if that's what you're dealing with. The diversion, is the patient, diversion meaning they're not taking the opioids at all, or maybe they're only taking a few, but the majority of them are going somewhere else for some other cause. Is the patient at risk for immediate harms? I'm seeing this, unfortunately, quite a lot these days. Patients, older patients on high-dose opioids having a lot of aspiration pneumonia events, leading to hypoxia and other problems. Bowel obstruction, a huge issue. Patients are not pooping like ever on opioids, and they're not necessarily going to tell you about it. Constipation can be a very powerful driver to get someone off opioids. If you have a patient who has really bad constipation, well, it will get better if they taper their opioids. Unfortunately, overdose. You might say that the patient is at risk for immediate harms if you can't monitor them in any way. If the patient's refusing any type of monitoring, a urine drug test, they're refusing to abstain from things that you're considering harmful, concomitantly marijuana or alcohol. The other indication being therapeutic failure. So if your pain is still 10 out of 10 and you're prescribed 300 milligrams of opioids, I think we can safely say this is a failure. Because your pain, shouldn't be 10 out of 10. These opioids are not working. Is the patient at risk for future harm? So do they appear to be benefiting in some way, but we feel that this dose is not a safe dose? Are they on concomitant benzodiazepines, those sorts of things? So thinking about future harms. I want to spend a minute to talk about this issue of substance use disorder or diagnosing opioid use disorder in this population. As Rachel and Lydia were saying, and we really talked about today a lot, making this diagnosis can be very challenging. And the reason is because there are lots of different adaptations that have occurred in this patient population over time if they've been prescribed opioids, and they've really kind of established ingrained behaviors in patients. And so our typical opioid use disorder criteria based on DSM criteria doesn't always fit. And sometimes it's hazy and it's not totally clear. And it may be slightly different for patients who have chronic pain than the opioid user. So for an illicit user, they're very, very clear procurement behaviors. They are going out, they're buying, heroin on the street, they're buying illicit whatever on the street, or they're getting it from a friend or whatever. There's some very clear behaviors that you can say, okay, that's not okay. They're, prostituting, they're doing whatever they're doing to obtain their drug. But for patients with pain, it's much more complex. They have a prescription that they've been getting continuously from you. That's not illegal behavior. They're coming to you, they're doing what they need to do on a regular basis. Maybe they're having their follow-up appointments, those sorts of things. So they're not really seeking in the clear sense of going out and trying to buy opioids illicitly. There are other issues of this memory of pain and pain relief and how that can be how that can affect this adaptation that they have experienced over time. They appear to be pain relief seeking. Pain is a very powerful narrative for them. It's very easy for them to talk about their pain and how they're really just seeking pain relief. And it's hard for them to disentangle that story. Many of them cannot see how pain seeking may be similar to opioid seeking and how that might be a problem. And this adaptation that has occurred over time is maybe their blind side. They're not able to see how that might be harming them. And so this, drug seeking versus relief seeking can be challenging. All of that said, there are ways that you can try to disentangle this, but sometimes it's very hard and you have to use your best judgment. You may not be able to have a slam dunk, this person absolutely has an opioid use disorder, but if you are doing what we've been talking about here, kind of focusing on safety, is the patient unsafe, are they at risk? Sometimes you don't have to have that slam dunk opioid use disorder, and you may find along a taper that you do uncover a lot of behaviors that weren't apparent when they were on 500 milligrams of morphine. And we can talk a little bit more about that if there are questions. Okay, so get ready, we're gonna do math. So how do you calculate a morphine dose equivalent? Well, this is a table that will help you. So we created this community standard and we developed 120 morphine equivalents per day limit. What does that mean for a patient who's prescribed fentanyl? What does it mean for oxycodone? So this table kind of breaks that down. When we're talking about 120 milligrams of morphine equivalents, we're talking about 30 milligrams of hydromorphone. Only measly 30 milligrams. And we're talking about 80 milligrams of oxycodone. So it's important when your patient's coming in and you're trying to determine, what am I dealing with? Where does this patient fall within the morphine equivalents per day? That you're converting whatever they're prescribed, oxycodone, hydromorphone, to morphine so that you can kind of gauge where they are on that safety scale. So that's your basic table there. Methadone, and I need to mention, we're not using this conversion or this table for opioid rotation. So this is not meant to help you determine what the dose should be for someone going from oxycodone to morphine if you're doing an opioid rotation. This is merely meant for seeing where they are in the scale morphine equivalents per day. So the morphine to methadone conversion or vice versa can be quite challenging. It's important to seek expert consultation if you're not sure how to do this. As you can see, as you go up in dose of morphine, the ratio of morphine to methadone changes. So again, this can be challenging. So if you're not sure how to do that, get some help. Hopefully you have a clinical pharmacist or someone in your practice or someone that you can call on to do that. All right, so get out your pen and paper. We're going to do some math with our friends at the table. So fentanyl 25 microgram per hour patch is how many morphine equivalents per day? Let me go back there. Yep. Who's got an answer? 90, okay. Anyone else? 90, ding, 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 good job. So it's pretty easy, 25 times your conversion factor of 3.6, you get morphine, 90 milligrams morphine equivalents. Okay, so hydromorphone 2 milligrams every 4 hours plus oxycodone 60 milligrams twice a day. That would be long-acting oxycodone. So you're dealing with a conversion factor of 4 and 1.5. Anyone have an answer? You can't play, I'm sorry. 228, that's right. So how did we arrive at that? So 2 milligrams by 6 tablets per day. So that gets you 12 milligrams per day times 4. The conversion factor gets you 48 milligrams morphine equivalents. And then your 60 of oxycodone times 2 tablets per day times the conversion factor of 1.5 gets you 180. Add them up, you've got 228. Methadone, this one's kind of hard. 23 times a day. Going back, trying to work on that. This one's tricky. So methadone 23 times a day. Anybody? So we're gonna multiply 20 by 3, and then we're gonna use either a conversion factor of 8 or 12, depending on which conversion factor you use, and it depends, because that ratio's, kind of tricky. So 60 milligrams of morphine equivalents could be, of methadone, could be up to 720 milligrams of morphine equivalents. Yes? Yep.
So that's a 24 hours, so his total dose was 60 milligrams in a day.
Mm-hmm.
So the conversion should be 4 to 1.
But you're going the other way. It's the total dose of morphine, yeah. So that's why it's tricky. That's why you have to think about, so the question was, why aren't you using 4 to 1? And the reason is because you're going the opposite direction. So the way this slide is written, and again, this is why it's tricky. We don't really know what the conversion the other direction is very well. So that's why we have to kind of extrapolate and say that it could be either 8 or 12. Okay. Seems like there are lots of questions. We can entertain some questions after I get through everything else. Okay, so we want to plan our taper and we want to start it. So what are some of the things you're going to do when you're planning your taper? Well, you're going to discuss your goals with the patient's goals and your goals. How and when will you know if you're successful? So do you have a dosing target that you're working towards? Does the patient have a dosing target that they're working for? And then what's your time frame? I think as we were talking about, trauma-informed care, it's important to make sure patients know what your plan is and vice versa. So if your time frame is, 1 month, that's a pretty important time frame you need to share with the patient. If your time frame is 1 year, well, that's different. It's also helpful for patients to know kind of what to expect. What are the dose decreases that they might expect during this taper process? Also talking about, what might they expect from their pain. Their pain level may increase temporarily, but it's usually short term during a taper. So it's important to kind of help patients understand that these are all things that you'll be talking about, discussing along the way and figuring out. Make sure they understand that they may develop withdrawal symptoms. If they do, what should they do? Who should they call? How will you deal with it? What are the things you need to do? Are you going to see them regularly? If they need to come in for an urgent appointment, can they? Nurse check-ins may be helpful during a taper with a nurse who knows what to ask for. When I first started doing this work and I would ask my nurse to call the patient, it actually backfired on me because the nurse said, "Oh my gosh, you're having a lot of pain? Oh my gosh, I'm going to get Dr. Weimer right away. It's like, that's not the response that I was hoping that you would have. I wanted you to say, okay, I'm sorry that you're feeling that way. Pain can be short-term during a taper. I'm going to let Dr. Weimer know that you're having withdrawal symptoms so that we can make you a little bit more comfortable." So it's very important that your staff is ready and equipped to help patients with this as well. Even from your telephone staff, if they're sort of reacting in a very reactive way, that can increase pain, increase anxiety, all these things. So helping staff understand what's happening can be quite important as well. And then I think it's important to try to identify a self-management goal along the way. So how will you help yourself, other than seeking medications during this time? What type of supports can you have around you? Maybe it's taking a walk every day or watching a relaxation video on the internet, things like that. Okay, this is a busy slide, but I tried to put it all kind of together in one table so you can say, all right, I kind of get this a little bit. So, thinking about the indication for the taper, Remember, that's your number one step, is you have to decide like how long it's gonna take, how you're gonna do it. You have to know, why am I entering into this taper with the patient? So based on each of those issues, we've kind of broken it down between what is the recommended length of time, what is the degree of decision-making around an opioid taper, and then what is the setting or the intervention. So discussing this line by line, if the patient has a substance use disorder, that could be an opioid use disorder, alcohol use disorder, what have you, the recommended length of a taper is none. If your patient has an opioid use disorder or alcohol use disorder, the safety of you, the risk of you prescribing them opioids is extremely high. They are not going to take the medication, or most likely they are not going to be able to follow a taper plan. They can't safely receive a medication from the pharmacy and know that they will follow the plan and take the medication as prescribed. They have a disrupted reward system. If they receive 80 pills of oxycodone, they could take all 80 when they get home. You can't know that that medication is safe. Similarly, if they have an alcohol use disorder and you prescribe them 80 pills of oxycodone, it is possible they will go home and take however many opioid pills they're going to take and a fifth of whiskey and die. You cannot assure that that medication is safe. We know that alcohol and opioids directly interact, and it can be a very unfortunate, fatal situation. So in the setting of concern for a substance use disorder, you have to be extremely careful. So I do not recommend a taper in that setting. I recommend that you are helping get that patient immediate treatment. That doesn't mean they leave the office without a referral. Maybe you can't assure them a stay at Cooper tomorrow or tonight, but you can give them a number and you can, check in with them tomorrow or what have you. Or maybe you do. Maybe you have your behavioral health specialist, make sure that they've got a bed somewhere and they're getting some treatment. I absolutely think that it's the humane thing to do to offer them medication to help them with that taper. Most of the detox centers in our community offer buprenorphine, particularly for opioid use disorder, and I think that that is the standard of care and should absolutely be offered to patients, whether that be admission to a methadone maintenance program or detox or transition directly to buprenorphine. Because these patients are at an extremely high risk of opioid overdose, I also think they should be leaving your office with a naloxone rescue kit. I'll show you some of those in a minute, but their risk of overdose, if they were to go out, obtain heroin or some other illicit pill, is very, very high. So the setting for that is inpatient detoxification if necessary, or an outpatient buprenorphine or methadone practice. If you prescribe buprenorphine in your practice, you could get them set up, start them the next day on that treatment if it's for opioid use disorder. Alcohol use disorder typically would recommend either hospitalization or outpatient subacute detoxification. Diversion, patients not taking the medication or you're not sure how they're taking the medication. Again, this is not a prescription that you can say will be taken or used in an appropriate manner. A taper is not indicated in this instance. So the decision-making is all yours. The same with substance use disorder. Unfortunately, in this situation, this is not shared decision-making. Whether they taper their medication or not, it is not safe. It's your decision. As their physician, to do no harm, you need to make the decision that you won't taper them at that time. And then as far as whether someone who's diverting their medication needs any type of weaning process or detoxification, that would really be based on a really frank conversation with the patient to understand how they're actually taking the medication, if at all. Okay, sorry to be so serious, but that was some serious talk. a little less serious. So if they're at risk for immediate harms, meaning the aspiration event, the bowel obstruction, the really severe constipation, those sorts of things, we're talking about a length of a taper of weeks to months. You really have to gauge it based on what's the severity of the harm. And then the degree of decision making on whether they taper or not is really moderate. So you're really saying that a taper needs to occur, but their views are going to be sought. So what do they feel like could be the first medication they can taper? Let them have some decision making in there. That usually goes a lot better. And so you're supporting their care, you're giving them a naloxone rescue kit if they're at risk for opioid overdose, and you're doing this in the outpatient setting typically. If they are failing, if they have a lot of concomitant mental illness, things aren't going well, you can certainly reach out for support at like a subacute detoxification center or buprenorphine. Though we need to be careful because buprenorphine does have many of the same risks as opioids because it's a partial opioid agonist, but maybe less so. Therapeutic failure, so this is the patient who's not getting pain relief, functional benefit, those sorts of things. These tapers are taking months. Again, it's sort of a moderate level of decision making, and so provider-led, but patient views are sought. And you are giving supportive care if they have opioid withdrawal, naloxone rescue kit. Certainly, most of the time this can be done in the outpatient setting and offering buprenorphine if they are not doing well with the taper. If they're at risk for future harms, so this is the high-dose patient, this can take months to years, years being hopefully not longer than 2 years, but some of these patients can take quite a while. This is the legacy patient or the lost generation that we were talking about. A moderate level of decision-making, and these patients may also ultimately benefit or do best with buprenorphine. Again, you're staying in that risk-benefit framework. You're really judging the opioid treatment and not the patient. These are some of the various naloxone rescue kits. They come as 2 injectable forms. This Benzos rescue kit can be quite expensive, but is new on the market. There's the syringes and the actual naloxone that you can prescribe, and then there's a nasal aspirator is another form. Most insurance companies are covering this now. Okay, so if you're doing a gradual taper, what kind of dose decreases are we talking about? We're talking about 5 to 10% decreases initially, and again, the time frame that you're using is really based on the indication. So you're doing these decreases every 5 to 28 days, potentially longer depending on the indication, until you're getting to about 30% of the original dose. And then you can kind of slow down and do it 10% based on that remaining 30%. Whether you taper extended release or immediate release first really depends on what seems to be the patient's views, but also if one is more expensive or easier than the other. I generally start with the extended release, but it really kind of depends on what you feel is the best thing to do. I like to give the patient a copy of the taper plan so that, again, they know what to expect, they know the time frame, and it helps kind of keep the patient moving so that when they come in and they say, hey, this thing just happened, my grandfather died, I just cannot possibly taper my opioids again, you can gently remind them, this is our time frame, this is what we've decided. Maybe you elect based on risk or risk and benefit that it's okay to hold off for a period of time, but you really kind of want to stay true to the taper and keep things moving. In my experience, when I've let things slide or sort of wait for several months, they don't tend to keep progressing. Washington has a nice site that you can use where you actually type in the short-acting dose, the long-acting dose, and it will give you an actual taper plan that you can print out for the patient. So certainly utilize that. That's available in your slides. that you can, absolutely show the patients. Rapid tapers, so these are for patients at a lot of risk, so you're maybe having daily to every other day reductions over 1 to 2 weeks as appropriate. Certainly your patients are going to have withdrawal symptoms with this type of taper, so you're wanting to use adjuvant opioid withdrawal medications, which I'll go over in a minute, offering office-based buprenorphine treatment or maintenance transition, methadone maintenance treatment in a federally qualified opiate treatment program, also very much standard of care and should be recommended. So the adjuvant opioid medications that you can use, clonidine is really, really helpful for the sympathetic tone that patients are getting. Hydroxyzine, so Vistaril or hydroxyzine is our friend, benzos are not. So for the non-benzo option is really Vistaril. You can use it pretty high dose. Certainly if they are, over the age of 65, you want to worry about, anticholinergic load, but you can really use pretty good doses of Vistaril during this period of time. For nausea, vomiting, Phenergan or Zofran, please be aware that Phenergan can be abused and is abused quite frequently, so if you're really concerned about side effects, then maybe use Zofran over Phenergan. Hycosamine or dicyclamine can be helpful for the abdominal cramping that occurs with opioid withdrawal. And then really trying to use other adjuvant, non-steroidal medicines, ibuprofen, Tylenols, those sorts of things. If they say they don't work, well, encourage they use them anyway. Make sure they're staying hydrated. The times that I've seen patients have problems is when they're having a lot of insensible fluid losses, they're getting dehydrated. Dehydration seems to worsen opioid withdrawal, so really trying to push the fluids, doing whatever they can to help. Hot baths, cold showers, whatever it is, to support them during this time. But if you're doing a gradual taper, typically patients don't have really, serious uncontrollable opioid withdrawal. It's for the more rapid tapers that patients would be experiencing that. Step 3.5, take care of yourself. I frequently will have people come in my office and sit down and just process a taper that went bad. Or I myself will call up a friend and say, I'm just exhausted from this. Whatever it is, check in with a colleague, process what happened, what went wrong, what was hard. This is hard to do. This isn't something that probably we would choose to do unless you're crazy like me, but you gotta talk about it. Having an opioid committee that can support you in your clinic, take some of the heat off of you is always helpful. And again, remembering that you are abandoning the therapy, the opioid therapy, not the patient. So for those patients who are just unable to taper, what do? These patients can be the patients on methadone, high-dose methadone for a long period of time, high-dose morphine, we're talking greater than 200 milligrams of morphine equivalents, greater than 5 years of use, with all mental illness, all the other things that we've talked about today. In these patients, buprenorphine is our friend. It seems to be an extremely important resource for these patients. Sometimes methadone is also indicated. If they're on very, very high doses of methadone, transition to a methadone maintenance may be a more appropriate thing for them. Patients will be hearing, as buprenorphine becomes more and more prescribed, patients will be hearing a lot of different things about buprenorphine. It's important to kind of know some facts about buprenorphine and help allay patients' fears of what it is and what it does. I certainly have a lot of patients who say, I would never take that medicine, it doesn't treat pain, like that's ridiculous. And so really kind of having some good information about that or referring to someone who can. And the interdisciplinary pain programs I think are extremely helpful, particularly for those patients who have a lot of distress or just really want to kind of get their life back in a very supportive environment. I think is a really important option. This was another quote from Jean Valentine from a New York Times article saying that few programs are in place to deal with patients now on high-dose opioids. and they're not benefiting from them. If the patients were taken off the medications, many would experience severe withdrawal or have to take addiction treatment drugs for years. Even avid believers in the new direction, like Dr. Ballantyne, suggest that it might be necessary to keep those patients on the opioids and to focus instead on preventing new pain patients from getting caught in the cycle. I think we are dealing with a lost generation of patients, she said. So that's where that lost generation came from. So does that mean that those patients who are on high doses should just stay on high doses? Not necessarily, but at a certain point, we might be dealing with a population of patients who we might have to I'm not saying we want to keep them on high-dose opioids, but we might have to think about other alternative treatments or other things that we can do to kind of reduce harm. But the patient who's been on, 500 milligrams of morphine equivalents for the last 30 years, it's going to be pretty hard to get them off of opioids. So again, I think different modalities of treatment, the interdisciplinary pain programs, the buprenorphine, the methadone programs, those for those patients may be the next step, or it may be a very, specific, monitored approach. You try to reduce harm as much as you can. This is a difficult situation that we are in, and I think it's important to acknowledge that. All right, we're going to talk about some cases here. So the patient has immediate risk for problems from their opioids. So this is a 50-year-old man. He has low back pain for 5 years, developing severe constipation, not amenable to any treatments. You decide that the risks outweigh the benefit. He's on relatively low dose of morphine, extended release. Taper plan for him. Oh, I was supposed to tell you. What kind of taper plan would you expect for him? So he's on, extended release morphine twice a day, immediate risks. How fast is this taper going to be? You don't have to talk to your neighbor, but kind of think about how fast would this be and how would you approach it. So unfortunately, you cannot cut extended release morphine in half. Once you do that, it becomes short-acting morphine, so that's principle number 1. Principle number 2 is because you can't do that, and because he's on relatively low dose morphine, you can change him to the immediate release morphine and taper that way. This is somebody who's having really severe constipation, so the period of time that you're going to do this is going to be a period of weeks. He's 50, he's a little bit older, he could be at risk for a serious bowel obstruction. So, a taper that is designed over a period of 6 weeks, gradually coming down over each time over those 2 weeks. So what if that same 50-year-old man was prescribed fentanyl 75 micrograms every 72 hours? Are you going to taper his fentanyl, or are you going to do something else? Actually, why don't you just shout out? What are you going to do? Taper the fentanyl, okay? Is that easy? Okay, so Tom's saying it can be. It comes at 62.5. Well, he has Medicaid and they don't cover that. Sorry. I've tried that before, by the way. So what you could do is convert him to a long-acting morphine or oxycodone. Might be a little bit easier. Again, you can't break the extended release. You got to keep the extended release whole, but you switch him to that. Again, if you're not sure how to rotate opioids, you need to get consultation. But switching him, say you switched him to a long-acting morphine, a possible way to do this would be, now again, this requires that you're prescribing 2 extended release morphines, but most plans cover this. So you're doing, say, a 90 milligrams in the morning, 60 milligrams in the afternoon, and 60 at night. And then you're gradually coming down by, 30 to 15 each time over a period of 2 weeks. So you continue until he's totally done. You absolutely can taper with the patches, and you could do a 12 microgram patch reduction. But in my experience, 12 of fentanyl is really like, what, 36, 40 milligrams of morphine equivalent. So that's a lot of a reduction at one time. So generally, patients would have withdrawal with that amount of taper. Okay, so a substance use disorder. This is a 50-year-old man prescribed hydromorphone, pretty high dose, fentanyl high dose for chronic pancreatitis. You detect alcohol on a routine urine drug testing, which could be done with an ethylglycuronide test. And he admits that he has relapsed on alcohol. What do you do? Okay, good. So you decide the risks outweigh the benefit, you refer for detoxification from alcohol and opioids, and you stop prescribing immediately. Third, so this is a 28-year-old female prescribed opioids for chronic abdominal pain. She states she lost her prescription for the third time. She's had 2 negative urine drug tests for the opioids and refuses to come in for a pill count. When I ask patients to come in for a pill count, I usually ask them to come in within the next 24 hours. That's on my opioid agreement so that they know that that could happen. It's important they know that if you ask them to come in for a pill count, it's, a pill count in real time, not in a week. So you suspect diversion based on this. What do you do? Right, stop. Use nothing, you stop prescribing opioids immediately. Case 4, I call this the lost generation with therapeutic alliance. So this is the 68-year-old female with rheumatoid arthritis prescribed 350 milligrams of morphine equivalents for 5 years, has no adverse events. She's moderately functional. You guys have developed a new opioid policy. She's falls into that policy, and she needs to attempt a taper. You are concerned that she might develop serious harms from her opioids in the future. What are you going to do? Okay, yeah, so a slow taper by 10% per month over a year. You may elect to slow down the taper if she experiences periods of worsening pain or withdrawal. But typically creating sort of a timeline is important. So a lost generation with hopelessness. So this is the long-term opioid patient, legacy patient who's very depressed, hopeless. 63-year-old man with low back pain, severe depression. His work injury was in 1982. He has not worked since, and he spends most of his days sedentary. He's unwilling to engage in additional pain modalities. He is prescribed high-dose, short-acting oxycodone every 4 hours. You've tried other opioids. He has not had improvement. He refuses an opioid taper and states that he will seek another provider if you start to taper his opioids. What do you do? You offer him buprenorphine or a 1-month rapid taper. This is a real patient. I can currently tell you that he also had an alcohol use disorder. He also was threatening to drink alcohol if we tapered him. So there was a lot of risk there. Ultimately, I'm still not sure what he's going to decide. He's in the hospital currently, so we're trying to hopefully he will choose buprenorphine. All right, benzos. We've got a little bit of time for benzos. I think I'm a little over schedule, so go as quickly as I can. Okay, so long-term benzos, many of the same issues as opioids, many of the same long-term safety and efficacy issues. There's clear risks that we know of, we talked about today, can cause a very severe physical dependence and withdrawal symptoms that, unlike opioids, can actually be life-threatening. So you can have seizure and have life-threatening withdrawal syndrome. Usually, this is very similar to alcohol withdrawal, though much less predictable, usually because patients who are abusing benzodiazepines are typically not taking a steady dose. They might be taking very, very high doses. It's usually characterized by anxiety, headache, sweating, concentration, anorexia, just really depersonalization, lots of sensory issues. Most severe, they'll have delirium or seizure. These symptoms can be very, very protracted after withdrawal or after stopping benzos. The symptoms can go on for 6 months to a year, post-acute withdrawal symptoms. They will frequently have reemergence or exacerbation of their original symptoms. So this can be a difficult withdrawal process. The most severe symptoms seem to occur in the quickly eliminated high-potency benzodiazepines, so your alprazolam, ativans, or triazolams. Essentially, just never prescribe alprazolam. It's probably like the worst, least effective, just highest risk benzo. I like Ativan more than Xanax of all of the withdrawals that I have to deal with. The Xanax withdrawal just seems to be just the worst. Patients also don't seem to understand that it's they're taking like 2 milligrams of it, and that's a whole lot of a benzodiazepine. They just don't see that's a lot of medication. Your intermediate severity is those that are quickly eliminated but low potency, like your oxazepams or clonazepams. The most mild severity, but still difficult, are the more slowly eliminated, lower potency diazepam, clorazepate, or chlordiazepam, whatever the long, you know what I mean. Okay, so your dose equivalents for benzos are written here. When you are designing a taper, it's important that you are similar to the morphine equivalents, kind of talking the same language, understanding how much of Xanax the person is actually taking, thinking about the onset of action and the metabolism and their potency. So these tables are pretty readily available online. Taper principles, generally, if you're in the outpatient setting at least, converting to a longer acting benzodiazepine, in my experience, tends to go better. The longer acting benzodiazepine actually kind of self-tapers a little bit as opposed to the short acting benzos, which are very quick on and off. Again, similar to opioids, the time frame depends on the indication for the taper. Rapid tapers can safely be done and effectively be done, but typically they need to be in the inpatient setting or a subacute setting, particularly in a patient who's not taking medication as prescribed. If it's an elective taper, these tapers can sometimes last up to 6 months or longer, and be difficult, unfortunately, the whole way. But sticking to it tends to go best. The first 50% tends to be sort of the easiest. It's as you get to the lower doses of the patient who's been on this medication for a longer time that you have more symptoms. Adjuvant medications for benzodiazepine withdrawal, valproic acid or carbamazepine. This is helping to prevent potential seizure, but also help with some of the mood stabilization that's destabilization that's occurring. Propranolol seems to be somewhat helpful in this type of taper. Clonidine or tizanidine, Visceral again, Prazodone for sleep, whatever you can use to kind of decrease some of the symptoms. So a case, actual case of a 60-year-old woman. She has dissociative disorder, alcohol use disorder that's been in remission. Actually, I see this very, very frequently. If you had an alcohol use disorder 20 years ago and then you got prescribed benzos, you probably won't have an alcohol use disorder anymore, but you'll still have a benzo use disorder. Because guess what? They do the same thing. So prescribed clonazepam 1 milligram every 8 hours for 25 years, but she's been taking longer. They are no longer effective, and she feels severely physically dependent on them. She absolutely wants to taper. She feels that they have taken over her life. She describes, quote, severe sleep deprivation, a burning spine, tremor, nausea, constipation, anorexia, night and day confusion, and having continual flashbacks. This is a hugely traumatized patient and just not doing well. Actually, she was brought across the country from Florida by her ex-husband to get care and had to be sort of removed out of her situation because she was just doing so poorly. She has no interest in going to detox or formal treatment. She feels abused and traumatized by the mental health system. She has been completely intolerant of any mental health medications, and she says that the only medication that helps her at all for any of her anxiety is lisinopril. Okay. So my taper plan for her was to convert her to diazepam. For her, it was really important that even though she was on a longer acting benzo, she really needed to kind of have a different benzo to taper. Typically, this would be a patient, you know, if she hadn't had a lot of supports, I would have referred for either an inpatient or subacute detox, but she had a lot of supports around her and she was very, very committed to this. So we switched her to diazepam, 5 milligrams 3 times a day. I gave her a 1-week prescription because I just met her and I didn't know what was going to happen. And I told her that her ex-husband had to be in charge of the medication, and we kept a very strict log and actually checked in with her multiple times during that first week. So she had very close follow-up. And we continued with 1 milligram decreases every 2 to 4 weeks, started Depakote and propranolol, and tried to get her engaged with mental health and addiction treatment. The outcome of that, after 11 months, she completely was tapered off of benzodiazepines. She engaged with Smart Recovery, which was the only mental health or addiction that she was willing to engage in, and it was very, very helpful for her. She was not able to kind of get past some of the traumatization she had experienced with previous mental health providers. And after her taper, she did continue to have some post-acute withdrawal symptoms, but she managed those, and she was very committed to staying off of opioids, or off of benzos. Okay, case 2, so the 21-year-old with anxiety and low back pain is using 1 milligram of alprazolam 3 times a day for the last 2 years, sometimes takes more than prescribed. Oh, and he's also prescribed oxycodone, 30 milligrams 4 times a day. What do you taper first? Dealer's choice. You get to decide. What should you do? Kind of depends on the situation, you know, what you're more concerned about. You could, if you're planning to taper the alprazolam, you're probably going to need to transition that to a longer acting benzodiazepine like clonazepam and decrease it over time. You want to be really careful about the prescription length. This is not a prescription that you're writing for 3 months at a time. So really close follow-up. You could do is alternate the benzo and the opioid, decrease one month, decrease the other month, or however quick your taper is. The other thing I just want to mention is that you are beware of the sedative hypnotics. High-dose sedative hypnotic use is on the rise. I see patients unable to get benzodiazepines. They start using high-dose Ambien or Lunesta or Sunata, carisoprodol, high-dose, basically no therapeutic use. Serious withdrawal symptoms can occur from abrupt cessation of these medications. Some of them may need to be tapered or referred to treatment. All right, time for a little bit of time for questions, but I do want to make you all aware that we have a free buprenorphine training coming up on April 29th. It will be at HealthShare. It will allow you to get your DEA X waiver. It will be half live, half online. So we'll do a 4-hour training that is live. Then we will do a 4-hour online training that you can do at any time. There will be CME that is free associated with that. And additionally, if you do that training program, you will be eligible for consultation with the OHSU Addiction Medicine program. So we will provide ongoing treatment and assistance in the office after you do that training. And if you're interested in that, you can get in touch with Marie Payment at OHSU, and I'm happy to take any questions about that training. All right, just a little bit of time for questions.
One is, thanks for the advice, but you really get a step where you have a goal, you're stopping at 120 mil equivalents, you're stopping at 0. Obviously, probably patient specific, but just kind of interested in what your goal is usually, where to stop.
I think it depends on the situation. If your patient is not having any benefit from an opioid, then generally my recommendation is total cessation. If they are achieving some sort of functional improvement, then I think you need to make a risk-benefit evaluation to determine if once you get to 120, is that sufficient? I think that 120 is a good, safe limit that we shouldn't exceed, but I also don't know that it's good enough to just get there and stop. Because in some people, 120 is still really dangerous and not safe. So it really depends on the situation.
I wanted to ask one more question. About how much quantity do you find yourself writing for withdrawal symptoms, like actual doses?
Generally, I don't need to exceed more than 0.6 a day. I think you can do up to 1.2 milligrams, but that's a lot. You have to obviously be careful about hypotension. But typically, 0.1 to 0.2, 3 times a day as needed is sufficient.
One more. Have you used clonidine for pain, not just for withdrawal?
I don't usually use it for pain. I've used it for like PTSD, anxiety symptoms, help with sleep. In my population, patients will abuse clonidine, so I have to be careful about that. So it's generally not my go-to, though. Yeah.
Other questions?
When you're doing a taper, what do you recommend the frequency of follow-up? It sounds like you have to maybe phone calls, follow-ups, or how does that work?
So the frequency of of follow-up during a taper. Again, it sort of depends on how rapidly I'm doing it. If I'm doing a rapid taper, then I'm going to follow that person probably every week or a couple times a week. I will ask my nurse care manager or triage person to call them and check in with them, just make sure they're not having any serious withdrawal symptoms, or I'll ask them to send me a MyChart message, and maybe we'll, have some follow-up over the, email. But if it's a elective taper, just over time, I generally see those patients every 1 to 2 months, kind of depending. And they kind of get used to it. They're like, all right, I got to come back and have this conversation again with her. It depends on how fast you're doing the taper. Yes?
I don't really have a question, but I just wanted to kind of explore the idea that even in a lost generation patient that we could bring them down. And I'm worried that as they age and their, kidney and liver function decline, and they may develop sleep apnea or other medical problems that increase their risk, should we try and taper someone at 500 morphine equivalent? Just as a discussion, not as a criticism.
Yeah. So should we, based on the somewhat probably controversial statement that maybe, lost generation patients, there's kind of no hope, like you can't taper them. That's not necessarily my opinion. I think that you should try to taper those patients. I've just found that can be very, very challenging. And in the absence of a community standard, what I've seen in the past is that I will initiate a taper in the patient and they will seek care elsewhere. And then I worry about, my colleague who's then assuming a lot of risk and may not have, a lot of resource to help that patient. So I always try. I absolutely always try a taper. I absolutely always offer buprenorphine. I offer interdisciplinary pain options. I do all of those things. Some patients with very, very severe mental illness or other things, depending on how long they've been on it, how difficult their dependency is, those sorts of things, you just might have to be pretty creative. I think you could get to a safer dose in that patient and maybe say, this is acceptable, but I'm not gonna stand up here and say that they should stay at 500 by any means, but you know, that might be the patient you get to 120 milligrams of morphine equivalents and you say, okay, we're kind of gonna, you know, back off here a little bit. But you know, I think it's a challenging situation to be in. I'm happy to hear what other people think too.
We'll take one more question before a break.
My question's about alcohol withdrawal. So is it ever appropriate in a primary care outpatient setting to prescribe Librium, you know, to allow the patient to detox on their own? If it is, then what considerations do you take if you decide or don't decide?
So should you ever do an alcohol detox as an outpatient? You can. If you are not an addiction medicine provider, I don't think I would. I think you could get into some trouble, particularly if a patient doesn't follow the taper as planned. You have to have a lot of resource available to monitor them, see them sometimes on a daily or every other day basis. You need to document so that you're making sure they're not getting into risk. So if you're not equipped to do all those things, probably not. It's a lot. I think it's a lot safer and more effective for them to be in a very, you know, controlled setting. So I generally wouldn't recommend it. What I will definitely recommend though is that you offer that patient medication-assisted treatment once they are detoxed from alcohol, because we have some very effective medications like naltrexone or acamprosate that can help a lot of people.